Hello everyone. You guys diagnosed it very well. It's a case of acute hemorrhagic pancreatitis. And if a patient presents to you with these kind of abdominal findings on examination with no history of trauma, there is definitely some pathology causing intra-abdominal hemorrhage. And with this specific presentation, that the patient is a chronic alcoholic male who presented with severe abdominal pain along with fever and features of shock and hemodynamic instability, then it is a case of acute hemorrhagic pancreatitis. And the specific characteristic clinical signs you can see here, there is this blackish discoloration around the umbilicus, and there is discoloration around the flanks. These are called Cullen sign when it is around the umbilicus, and at the flanks it is called as Gray Turner sign. Now let's discuss a bit about pancreatitis. It is a very common condition. It can be due to gallstones or chronic alcohol abuse, hypertriglyceridemia, post ERCP, post trauma, and due to some drugs, autoimmune causes, and there are a lot of idiopathic causes also. There are different theories for how pancreatitis occurs, but the core mechanism is premature activation of, or we can say intra-acinar activation of trypsinogen to trypsin that leads to digestion of pancreatic tissue. And along with digestion of pancreatic tissue, when that digestion leads to uh, necrosis of vascular walls, then it may lead to sudden hemorrhage and this kind of clinical manifestation when there is acute hemorrhagic pancreatitis. This Gray Turner and Cullen sign, along with features of hemodynamic instability, fever, uh, confusion, abdominal distension, signs of paralytic ileus also. And some investigations we can get increased amylase lipase levels, increase in CRP levels, and there is increased hematocrit and metabolic acidosis in ABG. And in the imaging studies, CECT is usually done, but it is mostly done after 48 to 72 hours so that we can get an exact picture of pancreas and how much necrosis is there in that. There are multiple complications also. One is this, you are seeing this hemorrhagic pancreatitis. Other complications can also occur. One is like pancreatic pseudosis, pancreatic abscess, splenic vein thrombosis, rupture of any pseudoaneurysm of the artery supplying the pancreas. In the management, it is usually supportive, and first is IV fluid, and the ringer lactate is the fluid of choice. In the severe cases, we need an ICU admission for this, and there is this Panther trial that states that there is a step-up approach for the management of necrosis in pancreas. Firstly, we try percutaneous catheter drainage, then we do minimally invasive necrosectomy, which is video-assisted retroperitoneal drainage, VARD. There are some indications of surgery also, like if there is persistent sepsis, we need to do a necrosectomy. If there is need of necrosis that is not amenable to PCT drainage, there is massive GI bleed or any rupture of pseudoaneurysm, and there is abdominal compartment syndrome or there is any obstruction. But the main thing is surgery should be delayed, and it should be delayed for at least 4 weeks. If it is done within 4 weeks, then the mortality in the cases of pancreatitis is very high. Thanks for listening, and you can share this brief review of acute hemorrhagic pancreatitis with your friends. Thanks for listening.